It's wonderful to be here. I want to thank the course organizers for inviting me, and on behalf of my investigative group, I want to kind of give you a brief update. We've been at this now for almost 3 years, and it's really been a wonderful opportunity to learn and really get a new sense of appreciation of the outcome for these very high-risk patients. First, there are a lot of causes of cardiogenic shock, and I think we want to be very specific because as you read the literature, and then specifically if you look at outcome data from large registries, it's very difficult to tease out why there's such differences in mortalities. And the area that I think has the largest overlap is a group of patients that develop out-of-hospital cardiac arrest. And in many of those patients, it's more of an arrhythmia than it is an acute infarct. And so you really can't compare those. And in addition, those patients have a lot of trouble with neurologic recovery. So we're specifically talking about acute ischemic dysfunction causing shock, either from a STEMI or from a non-STEMI. We heard earlier today that if you take a look here in Europe, what do the guidelines show? And there really is very little that is 1A indicated. There's no 1A indication. There hasn't been multiple randomized trials of anything in acute infarct, cardiogenic shock. I think here in Europe, you're able to do these randomized trials much more easily than we are in the United States. And as I understand it from Holger Thiel, there's, at least in Germany, there's a mechanism of doing sort of a prospective conditional approval. In the United States, we still need to get consent from either patients or families, and it's very, very difficult to do that. So the approach that we took after the Impella got approved in the United States is to really kind of design a prospective registry where we would treat patients in a systematic way and then measure outcomes. Still here in Europe, mechanical circulatory support has a 2B indication, very similar to inotropes, and more of the data that's being collected now I think is going to help guide us where we're going. Danger is going to give us very important information, but that's not going to be available for the next probably 3 or 4 years. And so tomorrow when a patient comes into your hospital with acute MI shock, how are you going to treat them? And that's what we're all kind of wrestling with right now. If we started looking at the IQ program, these are in the United States, every patient that gets implanted has some data that's collected by Abiomed in a commercial registry. And we saw that in the United States, there was a huge variation in outcome of patients that were treated with acute MI shock. And a third of the centers had survival that was under 30%. A third of the centers had survival that was over 75%. And the median survival was around 50%. And so there's a huge variation in care. One of the challenges with acute MI shock is that it's a relatively infrequent diagnosis or disease. If you take a very busy STEMI center that does 200 STEMIs a year, they're going to be treating 1 acute MI shock a month. And these patients come in at odd hours, 60% coming in at night or on weekends. And so it's very infrequent that one operator is going to have very compelling data. Certainly, single institution studies just are not going to work. And so if we're going to do anything meaningful, we all have to collaborate, and we have to do these studies on a large basis. And that was really what the genesis of the National Cardiogenic Shock Initiative was, is to get a lot of high-volume centers that are willing to collaborate and willing to prospectively collect outcome data. When we looked at the IQ registry, the things that were significantly associated with an improvement in outcome was use of the PA catheter, use of the Impella prior to PCI, and then use of the Impella as opposed to the 2.5 use of the CP device. And those are the things that were predictive. In addition, from the CVAD registry, we found that early initiation of therapy was important. Now, we took that data and we've kind of publicized it in the United States, and it's very gratifying to see that over the last 3 years, there's actually been a significant increase. So in 2019, for the first half of 2019, the survival had increased actually from 51% to 63%. And so really over about a 2.5-year period, there's been a 10% increase in survival for acute cardiogenic shock when the Impella is being used. And even more gratifying, there's a significant number of centers that are getting 80% survival to explant. So you can see that very quickly with adoption of some of these best practices and focusing, we are moving the needle pretty rapidly in the United States in terms of improving outcome of patients with acute MI shock. When we started the Detroit initiative, it was 5 institutions throughout Southeast Michigan. We wanted to see if we could adopt these strategies prospectively, so patients are getting identified early, treated early, systematic use of right heart catheterization, and we had a 76% survival. So that was the original initiation of our program, compared to the historical survival from the shock trial, which is 53% survival, and from the later Impress trial here, that was 52% survival. So we think that if we apply the same entry criteria from the shock trial and the Impress trial, that we are showing a substantial improvement in outcome. And so this is our team. Dr. Basir is our co-investigator, my co-principal investigator, and the group from Detroit. It is a study that is commercially sponsored by Abumed and by Kaiser Pharmaceuticals, but we really control the data and control the basically the trial structure. Very briefly, we identify the patients early, we do PCI, and then critically importantly, we do a right heart catheterization and use the right heart catheterization to monitor hemodynamics. If the patients have a CPO greater than 0.6 and a PAPI greater than 0.9, then they're followed with usual care. If it's less than 0.6, then we're trying to see whether or not there's RV dysfunction or not, and if not, consider escalation of care. Now, up until June of this year, we've enrolled 214 patients. 209 patients were excluded because they didn't qualify, and so we actually screened a large number of patients. For TCT, we're going to be having 250 patients that will be presented. So we're rapidly accumulating data in a very systematic way, and I think that we're going to learn a great deal, not only about overall outcomes, but more specifically how we can use hemodynamics to drive therapy. We have a combination of academic and community hospitals. I think it's very important to partner with community hospitals because 60% of the shock are presenting to non-university hospitals in the United States. And how those people are going to be treating these patients, I think, is critically important. Also, the concept of hub and spoke is going to be important. How do you really provide the care to the widest number of patients, and how do you get the treatment to the patients as soon as possible? If you take a look now, this is new data that I want to show you in terms of the revascularization. We wondered whether or not the culprit shock data was going to hold out. We have not really specifically asked the doctors to do either single vessel versus multi-culprit. So if you can see the single vessel disease with a single patient, 71% survival, 2 vessel either treated with a culprit only or multiple culprit, no difference. And then the same thing with 3 vessels. So we're not really seeing a signal from our trial that culprit versus complete revascularization really impacts. And we believe that's because there's less renal dysfunction when the patients are being supported. Reminding you that culprit shock, the patients were not supported in 70% of the cases. Here, when all the patients are supported, there isn't really an impact on increase in renal dysfunction with more contrast. So that it really does suggest that this whole idea of culprit only versus multivessel revascularization really needs to be rethought of when the patients are being supported with mechanical support. When we look at the comparison now of our study on the bottom, the NCSI compared to the shock trial, the balloon pump shock, the culprit shock, you can see that the patients are quite ill. Their blood pressure was 79/50, lactate mean was 53, lactate greater than 2 was 77, and our survival was 72%. So in comparison with the other larger studies that have been done historically, we're treating a very sick group of patients with severe LV dysfunction who are in severe shock and getting a 72% survival. And that number, I think, is going to be very constant, and we do think that we've had a significant improvement in outcome compared to the historical control. Now, switching briefly to identifying what factors could predict outcome, we took a look at the patients that survived versus those that didn't survive. Interestingly, the blood pressure is identical. So you do the angioplasty, the patients are on support. What's the blood pressure? Blood pressure is fine. Well, actually, you have to be more diligent than that. If you look at the right heart cath, you can start quickly to see that there's a difference in CPO, there's a difference in oxygen saturation, and there's a difference in the need for pressors. So blood pressure in and of itself is really not a very good predictor of outcome for these patients. And I think you have to delve more. And again, what we're trying to preach to the operators in the United States is that if you're going to use hemodynamic support, it's got to be driven by use of right heart catheterization. Again, looking at the variables of the survivors versus non-survivors, the PA sats are different, the cardiac outputs are different, and the CPO is different. And if you get a CPO greater than 1, you have an 85% survival. So very quickly, immediately after the procedure, you can stratify patients into those that are going to survive versus those that are not going to survive. At 12 and 24 hours, what you're starting to see is a difference in pattern. The blood pressures are slightly lower in the non-survivors. The lactate levels persistently elevated. Now the AST is starting to become elevated, so meaning that you're getting renal dysfunction and liver dysfunction in these patients very early on. And again, the cardiac output and the CPO really are segregating survivors versus non-survivors. And so our concept now is to identify these patients early, and the real question is, if you escalate these patients earlier, will you get an improvement in survival? And I'm anxious to hear the subsequent talks this afternoon about use of ECMO to see whether or not that could improve the outcome for these patients if you add that to Impella. Ionotropic support, I think, is a big problem. We haven't had a mechanism of avoiding the use of inotropes. You can see that in our data, if you're not on any pressors, you've got an 82% survival. If you're on 2 or more inotropes, you've got a 58% mortality. And if we take a look at these patients and delve deeper, inotropic use versus CPO, look at the bottom line. These are patients that have normal CPOs. If they're not on any inotropes, 85% survival. If they're on 1, 79%, and if they're on 2 or more inotropes, a 57% survival. So what this suggests is that it's not that the patients are sicker and require more inotropes, it's that if the patients are on more inotropes, they're going to have a worse outcome. The worst outcome is if you have a low CPO of less than 0.6, and then you're on 2 or more inotropes, and you've got a 30% survival. So that's kind of like has to be warning signs in terms of what's going to happen to these patients. Something more needs to be done for these patients in order to improve outcome. And the thing that's really important about this is data that is obtained immediately after the PCI is done. So as soon as you're done with the procedure, if the patients are still in persistent shock, it really suggests that something more aggressive is going to be required in order to get these patients to survive. Then, just to conclude, if you take a look at this data, the predictors of survival, on the lower panel, if the lactate is low and the CPO is above 0.6, you've got a 95% survival. On the upper right, if the lactate remains persistently elevated and the cardiac output is low, you have a very low survival. So I want to conclude then to tell you that in terms of advances in care, we've dramatically improved the outcome for these patients over historical control. I think the next series of concepts is going to be what further can we do to improve survival to over 80%. Thanks very much.
Thank you very much for the presentation. Let's have a single question now and more questions during the apéro to have sufficient time also for the other speakers. So who has a question?
So I noticed you reported the wedge pressure as differentiating survivors and non-survivors. What about CVP?
We haven't, the question is whether CVP segregates, and we haven't looked at that yet, Dan. I think it's really going to be important. We are presenting an abstract at TCT, and what we found is that 40% of the patients in this trial have RV dysfunction. And so that's going to be probably the next series of, because we've only supported about 10% of the patients with combination of right-sided support devices.
Right, that's kind of leading into the question of, is that a place for fruitful investigation?
Right.
Earlier initiation of right-sided support as well, combination.
I have changed my mind. Let's have more questions because this is so an important topic.
Subsequent to Dr. Berghoff's question, I wanted to ask you this concept because I've noticed that 42% of your patients were cardiac arrest.
Yeah.
And do you think that it's fair to include cardiac arrest patients along with cardiogenic shock? Because I think these are completely two different diseases. A patient who comes in with cardiac arrest, even if the patient is completely normal until this very second, after 10 minutes of CPR, 50 minutes of CPR, even after successful ROSC, we have LV failure, RV failure, and also global ischemia.
Right.
So do you think that putting all of these patients together would...
No, you're absolutely right, and we really try to exclude by CPR, it's transient CPR. So patients comes in, ST elevation, shock, and they go into VF in the in the emergency room. They get a shock, they come right back around. So it's really early recovery as opposed to someone that's down, prolonged CPR with no evidence of a culprit. So we kind of are trying to go through all of those cases to take a look to make sure that there is a culprit lesion that's occluded to cause the problem, and that's how we're enrolling them. If they have prolonged anoxic brain injury, it's probably not a good thing to do this because they're going to get their recoveries are all neurologic related and not cardiac related.
In our series, people with out-of-hospital cardiac arrest usually die of withdrawal of care
Right.
because of brain death.
Right.
Do you have any number of hemodynamic stabilization? So how many of these patients could have helped?
No, yeah, I'll tell you that in the CVAD registry, we had 51 patients that came in with cardiogenic shock and anoxic brain injury. And of those 51 patients, 46 died. So it's more than a 90% mortality. So, you know, if they've got prolonged anoxic injury and are unresponsive in the ER, I don't think that this is a good strategy. I think perhaps cooling, other strategies, but this alone is not going to give you a good outcome. They're all going to die neurologically.
Well, post-PCI hemodynamics, were those patients supported with mechanical circulatory support or a mix of supporting?
No, this is everybody. Everybody's getting treated with Impella, and then Impella first, PCI, and then we do the right heart cath and look at hemodynamics. So it's on support, and so there's still a substantial number of patients, even with a CP, that are not out of shock within the immediate post-PCI period.
Okay, thank you very much, Bill.